Hi there. My name is Callie Moyer, one of the co-chairs for the AEC this year. I'd like to introduce Karen Rareigh. She is an experienced pediatric genetic counselor and researcher with a special interest in genotype-phenotype correlation in cystic fibrosis. She has served as an integral team member of the CFTR2 website, which uses information from 88,000 patients in their database to provide clinical information about specific CFTR variants and genotypes, variant combinations, to researchers, patients with cystic fibrosis, and their families. She has previously given many talks to local and national GC audiences. Karen?
Thank you so much for the very kind introduction and also for the invitation to speak today. So the title of my talk is What We Are Learning from Cystic Fibrosis Modulators. I have no conflicts of interest to disclose today. And by the end of this talk, you should be able to interpret individual CFTR variants using either the laboratory report and or the CFTR2 website, and also summarize the types of CFTR modulator therapies and the kinds of variants that they target. So we'll get into all of that. So my brief agenda is that part one of the talk is going to be CF basics, very brief review of CFTR, CF, and what I call CFTR opathies. And we'll go through the CFTR2 website, terminology that we use, and how you might use the website. And then we'll get into treatment. So CFTR modulators, terminology associated with those, and indications for use, and sort of where we're headed with treatment. So part one, CF basics, and I promise I won't start so basic back at autosomal recessive inheritance, other than just to remind you that CF is autosomal recessive. But generally, I know that most people don't do CF every day, so I have just a few slides of the basic reminders. This is a multi-organ disease, cystic fibrosis, and its main morbidity and mortality risk comes from progressive obstructive lung disease. So the figure on the right that we affectionately in our lab call CF man shows kind of all of the different body systems that can be affected by this condition. The classic onset of CF that most of us learned about in grad school is generally in childhood, but the spectrum of CFTR related conditions has really expanded greatly, and we'll talk a little bit about that. But the classic triad for sort of typical CF is lung disease, pancreatic insufficiency, and male infertility. And at this point, we've really made good progress with treatment for cystic fibrosis over the years. And so individuals with the disease that are born in the last 7 or so years have a life expectancy in their mid-40s, which is really quite impressive. Here's your reminder about CFTR, the gene and the protein. So CFTR, the gene, encodes CFTR, the protein. This is the cystic fibrosis transmembrane conductance regulator. CFTR, the protein, is an ion channel for chloride mostly, and a little bit of bicarbonate. It resides at the surface of epithelial cells in the body, and the protein, to actually work and be functional, must be produced, got to make it. You then have to have it folded and trafficked, basically get to the right location in the cell membrane, and then it's got to be functional. It's actually got to let ions go through it. And so there's a schematic to the right here that just shows a functional protein with little green ions flowing through, and a non-functional one with the ions unable to get to the cell surface, get outside the cell. There have been over 2,000 unique CFTR variants that have been reported in various CFTR locus-specific databases, but only about a quarter of those have been definitively interpreted as CF causing or otherwise. And these variants may have varying functional impacts. I also have a quick little video here, if it plays, just showing a schematic, an animated schematic of chloride ions flowing through. So before I get into a little bit of the nitty-gritty of function, I want to remind everybody about function phenotype correlations in CF, because we're going to revisit this schematic when we talk about treatment. So generally, what we do here is start with CFTR function on the Y and then clinical phenotype on the X. And so if we're way at the bottom at either at or near 0% CFTR function, that's when we expect to see pretty classic disease, pancreatic insufficiency, early onset lung disease. If you bump up function just a little bit, a couple extra % of function, you can get into still CF, but potentially an amelioration of disease where we have pancreatic sufficiency. So the pancreas actually does keep producing enzymes, and potentially later onset or milder lung disease. Then in this sort of loose estimate of 10 to 30% of CFTR function, we get into what I call the CFTR opathies. And that's a reduction in CFTR function that leads to some sort of symptom, but not full-blown CF. So there are defined CFTR-related disorders like pancreatitis, bronchiectasis, male infertility. And then about 50% function, that's where we think the obligate carriers, most of whom are healthy, hang out. And then way at the top, these are individuals that have 100% CFTR function. We don't expect them to have any clinical evidence of CFTR dysfunction. So when we think about CFTR function, we got to figure out, where does it come from? And so this is a schematic showing how we get from DNA up to CFTR protein. So at the bottom, we've got DNA that goes to RNA, that gets translated into protein and folded in the ER. Then it gets kind of packaged up and trafficked, that's basically transporting it to the cell surface. So that bottom section talks about production of CFTR from a quantity perspective. How much protein are you making? Once it then gets to the cell surface, then we have to think about activating it and making it work. And that's where we get into the functional effects of CFTR. So is it actually working? Is the channel opening and letting ions through? And again, we'll get into why this schematic is important to understand when we get into treatment. Of course, as you can imagine, with so many different variants reported in CFTR, you could have a variant that affects one or many of any of these steps to get to functional CFTR. And so I've shown just a few examples here. I've underlined the most common variant, F508del, which most people know as Delta F508, and shown you that this actually has multiple impacts. So its main defect has to do with folding, but it also affects conductance and probably a little bit of gating. That's the channel opening and closing. So the question is, once you identify a variant, then how do you know what part of CFTR it affects and what impact it might have? And this is where I tell you a little bit about the CFTR2 project that I've worked on for the last 10 years. So CFTR2 stands for the Clinical and Functional Translation of CFTR. This is a global initiative to bridge the gap between our ability to detect CFTR variation and then interpret what it means for an individual. We have a website that outlines the project and which is searchable at cftr2.org. So our goals for this whole project, one is to analyze the variants reported in CFTR that come from individuals with CF across the globe. Then using that analysis, we determine and assign disease liability. That's essentially a variant interpretation to the different variants. And then we provide complete and expert reviewed variant interpretations online that can be accessed by anybody. It's a free and publicly accessible website, and it is geared to have language that is understandable both to the CF sort of scientific community, so researchers, clinicians, but also to what I would call the lay CF community of care providers, patients, and their families, et cetera. Our process is to populate the data set. So we have almost 90,000 patients worth of data in it. They come from 43 countries on 5 continents. So we have really tried to make this a global project. We then select the variants that have been reported in at least 3 alleles worldwide. These are the ones that we want to study. And then we analyze and assign the disease liability or our interpretation. And we have kind of a 3-pronged approach, where we look at 3 different characteristics associated with these variants. One is clinical analysis. So do the patients with them look like they have CF? Do they have clinical evidence of disease? Another is functional testing. And that kind of gets into identifying where in that functional schematic a variant might have an impact. Is it in the folding stage? Is it in the protein function stage of getting that gate open? And then we also look at population and penetrance of specific variants. So really with this assessment, what we're trying to make sure of is that if we think something causes CF, we don't want to see it in a person who's got, say, 2 copies of that variant walking around without CF. That would be an example of non-penetrance. So we look for things like that. And basically we have criteria set out. And if a variant meets all of these criteria to be CF causing, that's what we call it, and we put it online. If you go to the CFTR2 website, which again is available at cftr2.org, you have to click some checkboxes agreeing to our terms and conditions to get in, but then it's a relatively user-friendly website where you can search for one variant or a specific genotype. There's a little search box at the top. And then when you actually get onto a variant page, you get a variety of types of data at the top. You'll see different nomenclature for variants. Anybody who has worked with CFTR knows that we call things a whole bunch of different, very confusing and very annoying names. So we try to list them out for you. We also tell you whether that variant is eligible for any drug treatment. We tell you whether it's CF causing or some other interpretation, which I'll explain in a few slides. And then at the bottom, we give you a history of whether that variant has changed call over the years. This does not happen very often. Usually once we make a call on a variant, that's what stands, but every once in a while things change and you'll get a history of that here. Similar type of information when you search for a genotype, so a variant combination, you get information about nomenclature. whether the genotype causes CF or something else, and then history of the variants involved. So I do specifically want to go through the CFTR2 variant interpretations because they do differ a little bit than what you might see on a typical lab report. When we call something CF causing, it means that when we see that variant in trans with another CF causing variant, so on the opposite chromosome, we expect that person to have clinical features that are consistent with a diagnosis of CF. We expect that person to have CF. On the flip side, when we call something non-CF causing, that means that when we see a non-CF causing variant in trans with something that does cause CF, we do not expect that person to have CF. This term was chosen very carefully. It is not the same as benign. Non-CF causing means we don't expect that person to have CF. It means exactly what it says, but it does not preclude a person from having a CFTR related disorder or potentially very mild symptoms associated with other CFTR dysfunction. We also have a third category that's kind of in between called varying clinical consequences. These variants, when they are found in trans with a CF causing variant, may result in CF in some people, but not in others. Those who don't have CF, but have a VCC variant may have a CFTR related disorder. So this is sort of a in between non-CF causing and CF causing. Many of these variants are associated with variable expressivity or reduced penetrance. And lastly, we have a category that we call unknown or indeterminate. This means that after our group has done our whole CFTR2 evaluation, we still cannot determine disease liability of a variant or genotype. There may be multiple reasons for this. Sometimes it's conflicting data. Sometimes it's data that we just can't make sense of. And sometimes a variant does not nicely fit into any of the other three bins. But the important thing to note is when you look up a variant on our website and it says unknown or indeterminate, it means we have studied it. If you cannot find a variant on our website, it means we haven't studied it yet. So those are also unknown, but in a different way. And right now we have 466 variants available for search online. So importantly, I want to point out the correlation or lack thereof between the CFTR2 variant interpretation terms and the ACMG guided interpretation terms. I would suspect that most lab reports that you might receive about CFTR variants are going to have the ACMG interpretation, as that's what most clinical labs are using, whether that is for carrier screening or diagnostic purposes. Some of these are pretty obvious, right? So a CF causing variant that we say is CF causing is typically also going to be listed as pathogenic or likely pathogenic by ACMG interpretation. And VUS similarly, right? So if a lab thinks something is of unknown significance, it basically has the same meaning of our team calling it of unknown significance. I've already explained a little bit about our somewhat nuanced definition of non-CF causing, but this is very similar to what a lab might call benign or likely benign. You'll note, though, that one major category doesn't have a good ACMG equivalent, and that's varying clinical consequence, or VCC. There just isn't a good equivalent for this. We can't really call it a VUS from the ACMG side because the significance of these variants quite often is known. It's just sort of different. And as I said before, these are typically variants associated with reduced penetrance or variable expressivity. So this is just something to keep in mind, that when you see a lab report from a clinical lab that has a CFTR variant interpretation on it, it may not match exactly what you see on the CFTR2 website, and that's okay. I do want to give a word of caution, though, that when you get a lab report from a lab that has looked at CFTR and they report that something is pathogenic or likely pathogenic, it's really important to define pathogenic for what. So a non-CF causing variant may not cause CF, but it may be pathogenic for congenital bilateral absence of the vas deferens. Or a variant of varying clinical consequences may not always cause CF, but it may be pathogenic for a CFTR-related disorder like pancreatitis. So all this is to say is that you must pay attention to the fine print in the lab report. I realize I am preaching to a choir when I say this to genetic counselors, but I say it anyway, just to remind people that you may not see a direct correlation between a lab report and what you might see on the CFTR2 website, but hopefully you can use both in conjunction to help provide risk assessment for whatever the patient in front of you needs. Okay, so that concludes the first part of the CF basics, and now we're going to get into really the meat of the presentation and talk talk about treatment for CF. So there are some clinical terms that are important to know. I know for people who don't do CF on a daily basis, sometimes the terminology sounds like alphabet soup, so we'll just run through these briefly. So sweat chloride is the concentration of chloride in a person's sweat. That part is relatively straightforward, but it's important to know that the normal range is below 30 millimoles per liter, and the CF diagnostic range is 60 millimoles per liter or higher. And just for some context, the average sweat chloride for somebody with 2 copies of F508del, so this is a really classic, typical presentation of CF, the average sweat chloride is 102. And so the diagnostic threshold is 60, but most people with pretty severe disease are going to be considerably above that. People who have sweat chlorides between 30 and 59 are considered this gray zone or intermediate zone. Those are individuals who may have some evidence of CFTR dysfunction, but not necessarily diagnostic for CF. The other term you'll see a lot is FEV1% predicted. That stands for forced expiratory volume in 1 second. That means you take a big deep breath in, blow it out as hard and fast as you can, and the volume of air that you expel in the very first second is what we measure. That is typically reported as a percentage of the predicted FEV1 by volume without CF. So basically the predicted FEV1 of a person without CF who is matched on age, height, and sex. And this is the most common way to track a person's lung function decline over time. So a normal FEV1 is usually above 85 or 90%. Typically, when somebody with CF has an FEV1 that declines to 30% or lower, we start thinking about transplant. That's a very squiggly line. Lots of other factors go there. We also think about FEV1 decline as a trajectory. So is somebody losing several percentage points a year? Are they going down fast, or are they losing 1% a year for quite a while and relatively stable with just a short decline or a small decline? Typically, FEV1% predicted is also the primary outcome measure in clinical trials evaluating CF treatments. So the 2 things that we think about for clinical trials of new CF treatments are sweat chloride and FEV1. I would argue that sweat chloride is actually a better predictor because it's not impacted by things like cigarette smoke, environment. There aren't that many other things that impact sweat chloride beyond CFTR function. FEV1 can be a little bit more variable. On the flip side, though, when we evaluate efficacy of CF treatments, what we're trying to do is figure out if we can fix the thing that causes morbidity and mortality, and that's lung disease. There are also some modulator terms you should know. So the definition of a CFTR modulator is a molecular therapy that acts to improve production, intracellular processing, and or function of the defective CFTR protein. And these essentially treat the underlying cause of CF rather than just the symptoms. So typically until, I would say 10 years ago or so, we were treating CF on a symptomatic basis. We gave you therapies to help with lung clearance. We gave replacement enzymes for pancreatic disease. We give insulin if you develop diabetes, lots of antibiotics for lung infections. What we're talking about now is trying to actually fix the CFTR molecular defect. So there are 2 main kinds of CFTR modulators. The first is a potentiator. This is a drug that helps the gate of the CFTR protein open longer and more effectively so that you can actually get chloride transport improved. The trick with potentiators is that they require that the CFTR protein be relatively normally folded, and it's got to be located where it's supposed to go in the cell membrane. The only CFTR potentiator on the market right now is a drug called ivacaftor. There's also correctors. These are drugs that aid more in the folding and stabilization of the CFTR protein so that it can more effectively get to where it's going. So this kind of impacts a stage prior to potentiators where you're still folding the protein and getting it packaged up to get to where it's going. There are 3 of these. None of them are available just independently on the market, but they're compounds in other drugs. They're called lumacaftor, tezacaftor, and alexacaftor. So when we think about where these might have the biggest impact, potentiators are going to target the functional parts of CFTR. So up at that upper part of the schematic, once the protein has already made it to the cell membrane, they help conductance of the ions get through, and they help activity of CFTR. So they get the gate to open longer and they get the gate to open more and for longer. And the target of these types of drugs are variants that affect gating and which have residual function. Residual function variants imply that you've got a little bit of CFTR function. And really the only way that that happens is if you've got at least some protein that has folded and made it to where it's supposed to go. So that's really the main target of the potentiators. The correctors target steps that come before that. So they actually come in and help to stabilize the protein while it's getting folded and processed so that more of it can get up to the cell membrane. So when we think about the goal of CFTR modulators, it's really to restore CFTR function. That's what we want to do here. So if we go back to this genotype phenotype, or I'm sorry, function phenotype correlation, what we're really trying to do is take people who are starting somewhere near the bottom, either at 0 or near to it, and get their function up higher. We'd like to get it up to here, but we'll settle for here for now. And you can see that if we get function up on the y-axis there, we should see an amelioration of clinical symptoms because we might move somebody from pancreatic insufficient CF up into the realm of CFTR-related disease. And that would be a pretty significant clinical improvement. Ideally, we'd like to get everybody up to above the level of CFTR function that even carriers have, so we can get everybody into what we expect would be the normal range for healthy individuals. So that's the goal. From a logistical perspective, modulators are oral medications that are just taken daily. They are pills for older kids. The ones that are approved down for younger children, I think, have a suspension that can be given. I want to say they're taken once or twice a day, depending on the modulator. Currently, they are prescribed in addition to other CF therapies, though this is a question for debate. So there are actually some formal clinical trials ongoing to evaluate outcomes if you stop some of the other symptomatic CF treatments like chest physiotherapy and things like that. Anecdotally, we have heard that some patients are just stopping their other treatments on their own accord, sort of against the advice of their CF clinics. I have heard from some providers that there's kind of not a whole lot the CF clinic can say about this because for many of the patients, they're doing really well and they're not seeing any decline in their lung function and things like that. So we're trying to evaluate if we could replace some CF treatments with these modulators or if they really need to continue to be done in conjunction. Generally speaking, the medications are well tolerated for most people. There are some side effects. I'll get into a little bit more specifics in a few slides. And we're starting to have the opportunity to evaluate long-term use, particularly of ivacaftor, which was approved by the FDA in 2012. And so we're going on about 10 years of data for that particular drug, though it's a relatively small number of people that it treats. And so we still don't have tons of widespread long-term use data, but we're getting there. So when we think about the outcomes of CFTR modulators, they generally have the following effects. And there's a reason I defined these terms. So generally speaking, we see a sustained higher FEV1% predicted for people that go on modulators and a reduced rate of lung function decline. We also, generally speaking, see a sustained lower sweat chloride. And for some individuals, that may actually drop into the normal range. And so I've pulled some representative figures from some of the clinical trials for ivacaftor. And in both of these figures, the individuals in the trial that were on the placebo are shown in the black line. And so for the upper figure, this is looking at lung function over an 8-week period. And you can see that individuals on the placebo actually declined over that 8-week period. But individuals who were taking ivacaftor, not only did they not decline, but they actually went up and then stayed up for that 8-week period. And we now know from longer term studies and real world data that you can go beyond 8 weeks and still see these same effects. So you can extend this out for many months and years and still see that individuals on drug have a higher sustained lung function. Similarly, individuals that go on drug have a drastic change in sweat chloride that happens pretty quickly within 2 weeks and then is also sustained. So in the lower panel, individuals on the placebo had a sweat chloride that just didn't change. It stays right around 0, meaning there was no change in their values over an 8-week period. But individuals that went on drug actually had a pretty significant decline of about 50 or so points. And that means that if you started with a sweat chloride of 90, you might have lost 50 points after taking these drugs, and you can go down to 40, which you may recall is actually below the diagnostic threshold for CF. So depending on where you start and how good your response is, some individuals actually drop their sweat chloride into the normal range. And this is really a nice way of showing that CFTR is being affected by these drugs, because from a symptomatic treatment standpoint, we have never been able to treat sweat chloride. Even if you throw all the symptomatic treatments that you want at an individual with CF, get their lungs better, get their pancreas better, et cetera, their sweat chloride still remains high. So the fact that it's dropping here really shows that we are in fact correcting the molecular defect for this disease. There are other outcome measures that are looked at in the clinical trials. They're typically secondary outcome measures. So we see a decrease in pulmonary exacerbation frequency, decrease in hospital admissions, use of IVs, a decrease in breathlessness and coughing, and a potential or predicted lower rate of CF-related diabetes, which often develops in adulthood. On the flip side, we see an increase in a lot of good things as well. BMI, so a lot of individuals with CF have a low BMI or maybe underweight. We're seeing that improve on modulators. Better quality of life, oftentimes this means better sleep for people. They're coughing less, they're able to get better quality of sleep. We expect, based on the modeling, predicted increases in survival. We see increases in exercise tolerance and also in mental health. So lots of good things that are coming out of modulators. There are 4 modulators currently on the market in the US and in many parts of the world. I've listed them here and I'll go through them individually and then show you some other outcomes. So the first modulator that was approved in 2012 in the US was called Kalydeco, and this is just a single potentiator. It's ivacaftor. And it really targets variants that are known to affect the gating of the protein, which means the protein is folded and it's trafficked and it gets to where it's going, but it doesn't open. Either it doesn't open at all or it doesn't open for long enough. So the initial variant that this drug targeted was called G551D. And after that, the label was expanded to include other gating variants, as well as variants associated with residual function. So variants that have some working CFTR, but if you add a potentiator, you can get it working better. Next, in, I want to say 2015, we got approval for a drug called Orkambi, and this is a combination of ivacaftor and lumacaftor. So this is taking that same potentiator, but also adding a corrector to it. And you'll remember that a corrector comes in during the folding and processing to help stabilize the protein so you can get more of it up to the cell surface. Once it's there, then the potentiator helps it work better. This was the first drug approved to treat individuals with 2 copies of delta F508. So that's about 50% of the CF population. Unfortunately, it doesn't work quite as well. It works. You do get a bump in lung function and a lowering of sweat chloride, but not to the extent that we see with ivacaftor alone for people who are eligible for ivacaftor. Next came a drug called Symdeko, which is another type of potentiator plus corrector treatment. This also targets individuals with 2 copies of delta F508, as well as some people with other residual function variants. It's a very similar mechanism to the ivacaftor-lumacaftor combination, but it's a little better tolerated. You get a good response, it's not a great response. Then in late 2019, we really kind of won the lottery here with a drug called Trikafta. This is also referred to as the triple combination because it is 2 correctors plus the potentiator. So it is elexacaftor, tezacaftor, and ivacaftor. And I'll call it ETI, otherwise we talk about a lot of caftors in this talk. So this triple combination, or ETI, targets individuals who have 2 copies of delta F508, but also just 1 copy of delta F508. And that was really the kicker, in that it doesn't matter what the second variant is, as long as you've got 1 copy of delta F508, you are eligible for this drug on an age-restricted basis. And that covers 85 or 90% of the CF population just with this 1 drug alone. There was a label expansion for several of these drugs in late 2020. So there are now 183 different CFTR variants that are eligible for treatment. And Vertex is the company that makes these drugs. They actually have a very nice treatment finder website where you can go on, put in your variant or variants and age of your patient, and it will tell you what drugs are eligible based on FDA approvals in the US. So what I want to talk about just in the next few slides are what we call the highly effective modulators. I don't love this term, I'll be totally honest, but it seems to be sort of taking over in the literature. Basically, this is saying the drugs that work really, really, really well, where we see a significant increase in lung function and a significant decrease in sweat chloride. So I'll show you kind of what that looks like. So starting with ivacaftor, this is a drug that treats about 4 to 7% of the CF population if you have an eligible variant, and the eligible variants are listed over to the right there. This has the earliest or youngest approval. You can get this drug down to about 4 months, I think, and older. And the expected outcomes based on the clinical trials and emerging real-world data is a more than 10% increase in lung function and more than 50-point drop in sweat chloride. And you can see, compared to the last slide I show you, this clinical trial outcome at the bottom here goes out to 48 weeks. So the differences both in lung function and sweat chloride are certainly sustained over a long period of time. So this was really the first wonder drug for CF. And then the data came out for ETI, so that's the elexacaftor, tezacaftor, ivacaftor triple combination. This is the drug that treats at least one copy of delta F508. There's also 170 other variants that make that for which are eligible for treatment, and that covers about 90% or so of the CF population. This is approved for individuals 6 years and older. And the expected outcome is slightly better from a lung function perspective than ivacaftor alone. So you get over 14% point increase in FEV1 that is sustained over several weeks and years. And you get a 40 point or so drop in sweat chloride. Interestingly, this drug has some more side effects that have been reported. There are some liver abnormalities that have been severe enough in some individuals to take them off drug, headache, and some emerging data on emotional distress and mental health issues, which can be severe enough in some people to bring them off drug. So we're starting to learn a little bit more about that. A pleasantly surprising outcome of treatment with modulators is the potential effect on pancreatic function. So this is part of a figure from a paper that looked at use of ivacaftor in young children, so ages 12 to just under 24 months, individuals with CF, of course. And what this plot is showing is the weeks of treatment on the x-axis and the fecal elastase values on the y-axis. So fecal elastase is how we measure whether somebody is pancreatic insufficient or sufficient. They've put a gray line in here at 200 micrograms per gram. That's sort of the threshold for what we call pancreatic insufficiency if you fall below that. And you can see that each dot with connecting line is an individual patient. You can see that generally speaking, most people went up, meaning if you started your baseline around 100 micrograms per gram fecal elastase, there are some individuals that actually got up above the threshold for which we would call somebody pancreatic insufficient. This is a really big deal. Certainly BMI and nutritional outcomes are a real problem in individuals with cystic fibrosis. And this is basically showing us that we are fixing parts of the pancreas. So much of what I've shown you is clinical trial data, just because it's easy to access, it's abundant in the literature, but there's emerging real world experience, both anecdotal and published. Many patients are having outcomes similar to what we see in the clinical trials. There may be a decrease in effectiveness observed in the real world, mostly related to a more heterogeneous population on the drug. Certainly the individuals that take these drugs in clinical trials are sort of hand selected, and they have to meet rigorous criteria. When you give it to people in the real world, you don't necessarily have all that. And you have people that maybe are not super adherent to taking their drugs, but generally speaking, the outcomes are still very good. We have seen some discontinuation of the drugs due to severe adverse events. So we've seen some hypertension, GI pain or symptoms. There's some talk of cataracts for ivacaftor. Many studies have people that stop drug related to pulmonary exacerbations. That's a little bit tough because we expect to see that with individuals with CF. In some cases, it appears that the drugs have made it worse, and so they stop. And then what I mentioned before, we're seeing some emerging data with ETI related to mental health, neurocognitive, neuropsychiatric events. And this has included individuals that maybe had a baseline level of anxiety, of depression that was significantly worsened when they went on medication. For a handful of individuals, this has led to suicidal ideation or attempt, and the drug was stopped related to that. So I think we're still trying to get more information about that, but just something that we're keeping an eye on. This is not something that really emerged with the previous drug approvals. It seems to be coming out more with the triple combination of ETI. So how do the modulators change the long-term outlook for CF? Well, what we're really helping to do in restoring CFTR function is to change the trajectory of lung function decline. So we expect people over their lifetime with CF to have a decline in lung function. That's just sort of a given with this disease. But what this graph is showing you is when we change the trajectory of that decline, what does it do for survival? And so if you look at the bar or the line associated with a 4% rate of decline on the panel on the left, you can see that you get down to lung function of 20% around age 40 or so. And 20% we're calling sort of either mortality or a need for transplant. But if you change the trajectory of the decline to 1% per year, you don't reach that 20% threshold until you're 90 years old. And so then they translated this data and put it into the bar graph on the right and basically said the same thing. If you lose 4% of your lung function a year, we expect to go down to a very low level of lung function by about age 40. But if you can change the trajectory, even to 3% a year, you might get another 8 years of survival. And if you can change it to 1% per year, then we're not hitting that low level of lung function until age 90. Now, of course, these are models. There are lots of other things in the real world that may impact this, but this is what we expect to see over time. We expect that we are going to see a significant change in survival as the result of treating with modulators. I also want to put this out here. This is a quote from an adult with CF from the CF community blog. And she said, there's so much more promise out there. The promise exists not just for me, but for thousands. And really what she goes on to say is that suddenly adults with CF may have to think about concepts that they have never thought about before, like menopause and retirement and 401ks and what do you want to do after college as your job, because now you can work and are expected to work. I spoke with an adult with CF a couple of years ago who said, I never imagined having kids, and suddenly here I am, old enough to get married, and I think I want kids, and I've just never thought about that before because I didn't think I'd live long enough. And so these drugs are really having a significant impact on how we think about longevity within the disease. I think there has been talk over the last few conferences related to CF of getting geriatricians, right? Because we're going to have a very aging CF population, which is an excellent problem to have, but something we need to figure out pretty quickly. The last thing I want to end with, sort of new data here, is where we might be headed next with modulator use. And I'll show you a case report that came out last year and then maybe ask some questions about that we could think about for the future. So this was a case report out of New York State, and the title was Normal Pancreatic Function and a False Negative CF Newborn Screen in a Child Born to a Mother Taking CFTR Modulator Therapy During Pregnancy. So I'll summarize the case here. This is a CF affected mother, so a woman with cystic fibrosis. She has at least one copy of Delta F508. We don't know what her other variant is. That was not published. And she started taking the triple combination ETI soon after its approval. Interestingly, until that point in time, she had been unable to get pregnant. She and her husband had been trying to conceive and were not able to do so, but she became pregnant within about 6 weeks of initiating treatment. Her husband was a known carrier of Delta F508, but they did not pursue prenatal diagnosis for this pregnancy. They just knew that they were at a 50% risk because she was CF affected and he was a carrier. So at the 20-week ultrasound, there was some concern for possible echogenic bowel. Now recall that this woman was on ETI treatment for the entirety of her pregnancy, pre-conception and throughout. So at that 20-week ultrasound, there was some concern for possible echogenic bowel, but at the repeat ultrasound at 32 weeks, it either had resolved or was never there. Regardless, things looked normal at 32 weeks. So the baby was born relatively uncomplicated pregnancy and delivery and underwent routine newborn screening in New York State. So for cystic fibrosis newborn screening, we measure IRT, which is immunoreactive trypsinogen. It's a pancreatic enzyme precursor that is elevated in babies with CF and also some carriers. So the baby had a normal IRT level, and had they just followed the normal newborn screening protocol, that would have been the end of it. Normal IRT, negative, normal newborn screen for CF. However, knowing that this baby was at a 50% risk for disease, the mother's CF center actually just requested CFTR genotyping, which I think the state lab performed for them when the baby was 3 days old. And interestingly, found that the baby had 2 copies of Delta F508. So this is a homozygous Delta F508 individual that's very consistent with a classic kind of typical disease CF affected genotype. When the infant was evaluated by the CF center, she was over the 90th percentile for length and weight, had a very normal fecal elastase, so no evidence of pancreatic insufficiency. And the sweat chloride that was performed at 5 weeks of age was 60 and 67 millimoles per liter on right and left arms. Now that is diagnostic for CF. We recall that the diagnostic threshold is 60. However, that's considerably lower than would typically be expected for a baby with 2 copies of Delta F508. So in the table at the bottom there, I've just tried to put sort of the infant values for what was measured and then what you might expect for individuals with cystic fibrosis with a similar genotype to this baby. So the IRT value was 37. Typically what we see for other individuals with 2 copies of delta F508, somewhere 140 to 160, though it's quite a wide range, but 37 is obviously quite lower. And then, as I said on a previous slide, about 100 millimoles per liter for sweat chloride. This baby, though diagnostic, had a much lower sweat chloride. And really the fecal elastase, I think, is the impressive part here, where this baby is very pancreatic sufficient. That's a very normal result, and that's not typically what we see for a newborn baby with this genotype. So the next dilemma in this case, and I'll tell you, I don't have answers to this because the case just came out last year. There's not been any follow-up that has been published. So the baby is not eligible for CFTR modulator treatment based on her age. So the earliest that she could get treatment, I think, is 2 years, and she could go on the lumacaftor-ivacaftor combination. ETI, the triple combination, could be started at age 6. I think it's very likely, actually, the start age for ETI will drop sometime in the next year or 2. So my guess is this baby would not have to wait until she's 6 years old, but she can't get it now. At the time of the publication, the baby was breastfed, and we do know that CFTR modulators appear in breast milk, albeit at low levels, but they are there. So there was probably some degree of modulator that was still reaching this baby. And the question really in this case is there a way to consider some sort of bridge therapy that preserves really specifically the pancreas in this child who came out pancreatic sufficient? And boy, it would be really nice to keep her that way, but there just isn't a good way to do it unless the clinic is willing to figure out some sort of workaround or prescribe a lower dose of a drug. And that's a whole ethical discussion in and of itself, because there just are no FDA approvals for the drugs that would treat this baby at the age she currently is. So that sort of leads to the next dilemma or question, and I don't have answers to these, but I'll just pose them for people to think about. What about prophylactic treatment with modulators during fetal development, even if mom is not CF affected? You know, we now know that we have evidence that modulators do cross the placenta, and we have evidence from the case report I just showed that they can, we think, impact the CF disease course that develops during fetal development. We also have evidence from animal models that you can prevent onset of lung disease and meconium ileus by in utero treatment. But is it okay to do if the mom is not affected? The reason that this baby got treated in utero is that her mother had CF and so was on drugs for her own health. But what about carrier moms who, you know, either have a known affected fetus or at risk to have an affected fetus? What about that? Could they take modulators? Would bridge therapy become available if we started doing this? You know, what happens when you're giving treatment to a baby in utero and then they're born and they're not eligible? Would we be able to overcome that barrier? Would a prenatal diagnosis be required before considering treatment of an unaffected mom? By the time you could do a prenatal diagnosis, there might already be some evidence of CF, such as formation of the vas deferens or lack thereof in a male fetus. So would you require that a pregnancy progress long enough to diagnose the baby before trying treatment or not? And then similar question, at what stage in pregnancy is modulator treatment actually helpful? Could you start it late? Could you start it at 20 weeks? Could you start it at 35? So I think that these are all questions that a lot of people are asking, and that's kind of where we're headed with some of the CFTR modulator treatment. It was one thing and remains one thing to treat people that already have CF and to see if we can reverse and improve some of their disease. Where I think we'd eventually like to go is, can we prevent it entirely by starting these drugs early enough? I would be remiss if I didn't say a word of caution about modulators. This is a fact that is near and dear to my heart. So modulators are approved, as I said, to treat 183 unique CFTR variants. But I think it's important to point out that not all of these variants are known to cause CF. So of those 183 variants, just under half of them are known to be CF causing, and I'm using CFTR2 definitions here. About 20% are known to cause varying clinical consequences, so certainly could benefit from treatment in individuals with CF. But there's a remaining over a quarter of them that are either known to be non-CF causing or of unknown significance or have not been evaluated yet. So I just think that this is important to point out. Certainly there are individuals with CF who have non-CF causing variants. Now we think that they are not the cause of disease, but they are there. And it is certainly possible that if you treat them, you could see a clinical improvement. We know that even wild type CFTR will respond to modulators. You can take something with 100% function, throw modulators at it, and you can actually get above 100% function. And so we certainly expect that these variants that don't cause CF would respond. It just sort of depends on how much response and do you actually see a clinical improvement related to that. But the reason I point this out is that the risk benefit conversation just changes a little bit when you get into these variants that are not definitively known to cause CF, because the drugs, for one, are very expensive, and for two, are not without side effects. And, you know, for some people, those side effects can be severe. And so it's just important to keep this in mind. So I also wanted to just mention before we close out that there are some things that CFTR modulators cannot treat. Generally speaking, these are genotypes or variants that result in no protein. I'm sure you've noticed that in order to get an effect from modulators, they both, even potentiators and correctors, both function or both act on CFTR protein that is being produced. If you have a variant that doesn't produce protein, there's nothing for the modulators to act on. And so those patients kind of fall into two categories, actually, of people who are uneligible. One is the group I'm talking about. These are people who are not eligible for modulators because their genotypes are untreatable. There are a variety of other therapies under development, read-through agents to get through nonsense variants, suppressors of nonsense-mediated decay, RNA and DNA editing tools, CRISPR, full gene replacement. A lot of these are under development, and some of them are even in preliminary clinical trials. And then there's a group of patients that are ineligible due to having a rare genotype. So these are people who have a genotype with at least one variant that actually might make CFTR protein, but it's rare enough that nobody has studied it. And so we just don't know. So it could actually be a really good modulator responder, but nobody's been able to investigate it yet. So in these types of cases, it might be worth considering N-of-1 studies, including ex vivo studies where we get primary cells, grow them in the lab, test different modulators, and then predict whether the patient would respond, or just a trial of modulators. Some places will do this where they'll put you on a modulator for 6 to 8 weeks and measure sweat chloride and lung function and see if you respond. I want to bring this up specifically because individuals who are ineligible for treatment due to a rare genotype that hasn't been investigated may be more likely to be non-white. Most of the variants that were investigated for their response to modulators were investigated because they are at some threshold of frequency within the CF population. And as we know, the CF population certainly skews toward a white European-derived group. But we know it affects all races and ethnicities, and there are non-white individuals with CF. The genotypes in those individuals may be more rare and consequently may not have been studied yet. So, you know, anecdotally, just hearing from clinicians, we hear a lot about the last 7%, and those are the people who are not currently eligible for modulators. But I've certainly talked to clinicians that practice in areas that have a larger non-white population that say, no, it's 20 to 30% of my clinic that's ineligible for modulators. So this is something that the CF community really needs to keep an eye on. We need to make sure that we are being all-inclusive with testing of these different variants. There are several groups that are doing what we call serotyping to get a sense of what variants will respond. And so a lot of these patients may be able to find studies that can help them figure out if they're eligible for drugs. So we'll wrap up here. I have two kind of take-home point slides. So kind of bridging part 1 and part 2, interpretation and understanding of CFTR variants helps with risk assessment, anticipatory guidance, and identification of possible treatments. We know that CFTR modulators treat the underlying cause of CF and are likely to significantly change outcomes in the future. Better lung function, you're going to get a longer lifespan, better quality of life, people are happier, more content. Right now, we have over 90% of the CF population treatable by modulator. Now that's US population as a whole. Again, as I just said, there are going to be specific subsets of the population that it's actually a much greater percentage that are not treatable. And really all this is to say is that counseling for either a CF carrier couple or a newly diagnosed family really must be tailored to the specific known or expected genotype, because now we're able to say different things about CF depending on the variants identified. And so what are we really learning from the modulators? Well, we're reminded of all the ways that non-functional CFTR can affect the body because we can see what improves when we fix it, right? So we can see, yes, a lot of it comes down to lung function and things like that, but we're seeing people able to hold jobs full time that they weren't able to do previously. We're seeing increase in weight. For now the second year in a row, there's going to be a session at the CF meeting this year that talks about obesity in CF. This is not a problem we thought we'd ever have. We may need to rethink our approach to nutritional advice because of that. We're starting to see sort of things swing the other way. And anecdotally, I've heard about at least 1 or 2 patients that have discontinued their modulator use because they've said, oh, I'm getting fat and I don't like that. So we may need to really change our approach to nutritional advice in this population. We also may need to focus on aging with CF and planning for previously unthinkable milestones. So individuals with CF may have no idea what saving for retirement means because they didn't think they'd get there. And now we're having to have those conversations, which is excellent, but we need to do it right. And generally speaking, what we're learning is that when you can correct a molecular defect and result in systemic improvement, this is possible. And I think that this was just a nice lesson overall for genetic conditions in general. CF did sort of a new pilot way to do this in high throughput screening of small molecules to identify all these treatments. And I think that that's a model that could be applied to a couple other conditions. So I'll end there and say thank you. My email address is there. Please feel free to reach out to me with CF or CFTR related questions, and your CEU code is there. Thank you again for the invitation to present.
Thank you so much, Karen. That was wonderful, as usual. Incredibly interesting and helpful information. Earlier in our conference, in our live conference, we heard from a family who is in a study which is studying 2 to 6-year-olds with Trikafta. And one of the things that came up in the conversation was downsides of being on the medication. And I thought it was interesting because I hadn't heard yet, and I work in a CF clinic, that the Trikafta had been associated with increases in mental health issues, but she sure knew about it and she sure was concerned about it. So I think it's interesting because even if we don't decide to emphasize certain issues, they get emphasized themselves in the community because the community is very much on top of these issues.
They are. There's, I mean, as you probably know, or anybody who's worked with a CF family or community, they are incredibly tight knit. There's a lot of chat forums and Facebook and messaging and all sorts of stuff that goes on. And I in some ways, the community's almost better informed, I think, about some of these emerging side effects than the physicians or the care teams, because, you know, they come in every 3 months if they're healthy, but if people are seeing these side effects at home within a week, they're going to talk to other people about it. And so there was this really nice review article that looked actually at all the studies and pulled out, you know, oh, this study reported 1 adverse event related to mental health, and this study reported 2, and this study reported 1. And it kind of said, everybody seems to know there's like these one-offs, but when you aggregate them, they're not just one, it's actually a group of people. But by then the community sort of anecdotally had already said, oh yeah, we're hearing this, we're seeing this, this is what my patient told me. So it's really interesting. I don't know sort of what to do about it. I think for some individuals, it has meant tweaking their antidepressant or anti-anxiety medication that they were already on, or potentially initiating that. But it does become a risk-benefit conversation. There have been some people, as I said, who discontinued their modulators because of the severity of the mental health effects, which is really unfortunate because for those individuals, it meant that the quality of life they were getting from a lung perspective did not outweigh the negative effects on their mental state. So I don't have a solution. I know it is certainly now more mainstream to be aware of and look at.
Sure. And it's interesting to think about how you would evaluate for those issues in a 2 to 6-year-old as well.
Yes, that's certainly most of the trials in which this was reported are adults, like teens or adults. The young children are kind of a different ballgame in that way. So yeah, it's a tough group to kind of notice and to evaluate on a validated, systematic way, I think.
Sure. Thank you. Olivia, did you have any questions?
My only question was, are abnormal poly-T and TG tract lengths available for modulator use?
Only when associated with R117H. So that's an excellent question and near and dear to a lot of people's hearts who are trying to get 5T approved. Right now, the R117H variant is eligible for treatment, and it does not matter whether it's with a 5T or a 7T or anything else. If you do not have R117H, but you just have a 5T, that is not eligible for treatment, unfortunately, at this point. It should respond based on what we know about function of CFTR alleles containing poly-T variation, right? We know that they have some function, so it is logical to think that it would improve if you put modulators on it, but it does not appear to have been studied systematically either in a laboratory or by clinical trials, so there is no FDA approval at this point.
Thank you.
Okay, wonderful. Thank you so much. We appreciate you coming and talking with us today.
Thank you.
Thank you, Karen.
Bye now.